Some housekeeping to begin with. Today's session will be recorded and be made available on the NCAS website after this session. If you have any questions, please put them in the Q&A at the bottom of your screen, and we'll have some time at the end of Fergus's presentation to go through some of those. It remains to introduce our speaker for today, who very kindly is joining us at midnight in France. This is Fergus Allerton, who graduated from the University of Bristol in 2004 and completed a residency in internal medicine at the University of Liège in Belgium. He's a diplomat of the European College of Veterinary Medicine and currently works at Willow's Referral Service. Fergus is actively involved in veterinary antibiotic stewardship and contributed to the development of the Protect Me guidelines, which some of you will be familiar with. Within ENAVAT, he is working on recommendations for antibiotic use for surgical prophylaxis. He's the current editor of Companion and the 10th and 11th edition of the BSAVA formulary, and is also a member of the WSAVA Therapeutic Guidelines group. So please, can we welcome Fergus, and would you like to start sharing your slides?
Yep, let's have a go. Hopefully that has come up. Okay, thank you very much for the introduction, and thank you very much for this opportunity to be here today. It is a great opportunity, and hopefully we're about to have a storm in, I'm down in the Alps at the moment, so if there is any internet problems, it's probably due to that. But we're going to talk about engaging the missing stakeholder and really concentrating on talking about why the pet owner is so important in some of the conversations we're having around antimicrobial stewardship. And so during the next 45 minutes or so, I'd like just to introduce a few points about some of these conversations. And the first relates to the frightening numbers that we are often confronted by and whether they're useful or not. So we'll talk a bit about that. Ri kindly mentioned that I've been involved with Protect Me and the ENAVAT guidelines, and I think guidelines are a great thing. They're brilliant. They are very much focused on the veterinary practitioner, the prescriber, and we'll look at whether that's appropriate and whether it is achieving what we want it to achieve. Because if you've got lots of guidelines, are they just sitting in a guideline graveyard somewhere and not delivering the changes in prescribing behaviour that we would really like to see? So are they doing what they're supposed to be doing? And if not, why not? And I want to really focus on some pet owner resources, which I think may be, hopefully, part of that key to turn things around and to put some of the recommendations we have in the guidelines into practice. How can we actually change that from a paper recommendation into a meaningful action? And the first thing to say is why we're all interested in this is through the dangers and the human One Health threat from antibiotic resistance. And these numbers will be familiar to you. This is Lord Jim O'Neill's work back from 2016, predicting that 10 million people will die by 2050 per year, more than die from cancer currently. So massive, massive threat. Apocalyptic threat to human health. 10 million is the population of Sweden. It won't target the Swedes, I shouldn't think, but it will take out a large number of people. And so this should be something that frightens people. It should be something that you think, well, if it's going to kill that many people, I'll sign up and I'll do whatever it takes to avoid this. But interestingly, some work published I think earlier this year or end of last year, highlighted that sometimes these sort of themes, these ideas of the apocalypse and anchoring with such high numbers could be actually achieving the opposite if we want it to. It might make people turn off. And they're up against this a bit with climate change as well, and trying to convince people to buy into those small actions that cumulatively make a difference. And maybe we're doing the wrong thing. So initially, these numbers were questioned because they were created by an economist, and we now know that they are probably reasonably accurate based on the work done in the Lancet, but maybe this number is creating the wrong themes and isn't the message that we should be focused on, especially not when speaking to pet owners. And we'll come back to that a little bit later on as well. Protect Me has been, this is the third iteration now of the Protect Me guidelines. There was a blue one and a red one before that, and they do get changed as new evidence is published, and we hope that these guidelines are useful to vets. We've presented it in the format of a poster, but there are a whole host of different antimicrobial stewardship guidelines available across Europe. This is the list, if you like, of different documents or resources that are available across Europe. And we didn't extend this outside of Europe because this was some of the early ENAVAT work focused on that area. But it shows that depending on your linguistic abilities, there are a whole host of different options to try and drive home these messages. And these are dedicated really for vets in practice. How can you optimize your antibiotic use for certain conditions? And Scott Weiss has now made this available in an app form. So those of you who aren't available, I strongly recommend downloading Scott's First Line app. A really nice way to have really at your fingertips some excellent guideline information. And we looked, again, this is just European data, but we asked vets a little bit their prescribing or their hypothetical prescribing practices. What would you do in certain situations? And we compared that behavior against awareness of antimicrobial stewardship guidelines. And there is an encouraging correlation. So the more aware different nations were of antimicrobial stewardship guidelines, the better their antimicrobial stewardship behavior was likely to be. So that's encouraging. That tells us, right, maybe these things could work. Maybe you could drive change. And the dots that are coloured green or turquoise, they are the countries that actually have their own national guidelines available. So they're clustering at the top end. So again, suggesting maybe that if you do have national guidelines, they might help change behaviours. And so that was the positive side of things. And that reinforced those who are involved in guidelines to keep bashing away at it and trying to do that. But there are some concerning findings, and the counterpoint to that work was this study performed in the UK, and they were saying, well, what proportion of dogs that are referred on had actually had antibiotic behavior or prescriptions that were in accordance with the Protect Me guidelines. And you can see that for the animals that had received antibiotics prior to referral, a disappointing 70% were not in accordance with the Protect Me recommendations. So vets do diverge from these recommendations quite frequently. And another study, again looking at Protect Me, and this is the blue version. So we have adapted it. We've tried to recognize some of the limitations that we had. But again, they tried to instill some of these behaviors in practice, and they did achieve some great stuff. They helped reduce prescription rates of cefavecin in cats because we were keen to drag that down. We said, stop using this highest priority, critically important antibiotic for cat bite abscesses. And so vets did buy into a bit of that. But then they use other antibiotics. They don't switch the antibiotic off, they just change the antibiotic, and overall we end up using more amoxiclav. So is this an unintended consequence and a negative? And we need to look at that. The Veterinary Medicines Directorate have been recording antibiotic use, and actually I should say it's antibiotic sales. So we have a lack of really good quality usage data at the moment, and trying to get that out of our practice management systems is proving incredibly challenging. So on a national basis, we tend to rely on sales data. And to make this a fairer comparison, they have converted this into a defined daily dose, just so that you can't game the system and switch to cefavecin and get away with it and reduce your total use. You get penalised appropriately according to how much antibiotic you're actually administering. So I put this graph up just to show that over the last 10 years or so, we haven't made a massive impact on antimicrobial stewardship in the UK. So despite these different guideline documents, we still have similar levels to what we were dealing with 10 years ago. So there is still room for improvement. And we can do this sort of audit process at a practice level as well. And I think these can generate some really interesting information. And this is just looking at 3 sentinel antibiotics, so cefavecin, metronidazole, and enrofloxacin. And I put this up. These are different vets, all different vets using different amount of antibiotics over the course of a 3-month period. And quite a lot of this will be appropriate use. I'm sure these vets are doing things very, very well. But I just wanted to highlight that there's a massive heterogeneity of individual approaches to antibiotic use. So you can see there, if you're familiar with the Lord of the Rings, Boromir massively using metronidazole, way more than his colleagues. And you then have to say, well, is that a different caseload they're seeing? Is there something unusual about it? And when you ask them, actually, probably it's not. It's just they like to use metronidazole as a treatment for acute diarrhea. And when they then are confronted with the fact that Frodo and other dwarves or hobbits, whatever they are, they can get away with much lower uses of the same antibiotic for the same caseload, that can be a way to challenge their behaviours. But overall, we know that vets are overprescribing antibiotics for very common presentations that probably don't require that type of antibiotic use. So David Singleton's work, a bit old now, but has been reinforced by study after study. Acute diarrhea accounts for 30 to 80% of presentations with acute diarrhea are receiving antibiotics. And there are some ENOVAC guidelines now specifically on this subject that have really analysed all the available data out there in the veterinary literature and have shown that there is no evidence of a meaningful difference, a meaningful benefit from antibiotic use in that clinical scenario. So we should not be using antibiotics in 1 in 2 cases of canine acute diarrhea. These should be very low single figures. And again, demonstrating that there is plenty of room for improvement in the future. And within the Protect Me guidelines, we reiterate those recommendations that antibiotics are not indicated for acute vomiting, acute diarrhea, and even for chronic diarrhea, where metronidazole is again a common favourite. But why then does have the Protect Me, we're version 3 now, this should be bedding in. Vets should be looking at this poster on a daily basis. They should be reminding themselves, okay, don't need antibiotics for a diarrhea. And every case they should see, they should be arguing and refusing to give the antibiotics. But why don't they? Well, guidelines can be ignored. At the moment in the UK, we have prescriber autonomy. In some countries in Europe, even in France, if you want to use, for example, a highest priority critically important antibiotic like a fluoroquinolone or a 3rd generation cephalosporin, you can only do that if you have culture and susceptibility testing that supports that choice. So those countries are starting to introduce legislative measures that effectively impose formulary restriction. So the sort of restrictive form of stewardship is coming out. In the UK and in the majority of the rest of the world, my understanding is that we rely on enablement and stewardship. We're relying on people adhering to recommendations and saying, okay, I buy into that and I'm going to adjust my behaviours accordingly. But they might feel that actually this particular animal is slightly different and maybe it's particularly unwell, or they're worried that it might be that case that is infectious and does need antibiotics. So they play that defensive card and use antibiotics just in case. Or maybe they're just because they're not sure what's going on. Maybe the diarrhea is just the tip of an iceberg and there's something more systemically serious. However, the real one that worries us is that, well, the owner came in and that was their expectation. They came in wanting an antibiotic treatment and that's what they're paying for. They've signed up for this consultation and they want that treatment. They've had it before, my colleague's given it out and their pet's got better. So now they've come in and they expect to leave with a pot of pills that are going to sort their pet out in a matter of days. So vets cite client expectation, client pressure as a major motivator for antibiotic use. And some brilliant work done by a group at the University of Caledonia found that, well, actually, maybe this is a perceived pressure rather than a real pressure in some cases. Maybe owners are actually more attuned than we think, more than we give them credit for, because when they were, same owners who'd received antibiotics, when they were interviewed in the car park afterwards, they said it wasn't us that had got the vet in a headlock and forced them to hand over those antibiotics. Actually, it was the vet driving that decision making. So there is this discord and disagreement as to who's really to blame. And maybe we underestimate some owners and maybe they would be more receptive to some of these messages if we afforded them the chance and tried to talk them through why we are making a decision. So I think we need to be in step with some of our pet owners. We need to try and say to them, look, we have seen the guidelines, we want to adhere to them, we want to do the right thing. Will you come with us? Will you understand why we're making those decisions for your pet? It's in their interests and it's in the wider interests of wider society as well. And just to highlight that all guidelines that we've been making, certainly through ENOVAT and even with Protect Me, we want to make them transparently. We want to make them in a way that is rigorous, robust, defendable, so that they can be used to support vets when they're making those decisions, and so that those vets can have confidence in the recommendations that we're doing. So we have been using the Agree To framework as a sort of way to ensure that the guidelines are good quality and they are methodologically rigorous. And Agree To is a way to do that, but it's also a way to appraise existing guidelines and to look and see what they are, how well they have been constructed. And we did this with those guidelines that I mentioned previously in Europe. We looked at these 6 different domains. And the one I want to highlight is domain 2, which is that stakeholder involvement. So when those first guidelines were originally sort of being made, it was often a case of getting a few eminent people around a table saying, well, what do you do? I think that sounds reasonable. Let's put that down and see if everyone else will buy into it. Well, maybe it's better to ask people. Maybe we should be saying, well, you're in practice, you're seeing these cases. Why do you give antibiotics? And would you be receptive to this particular suggestion withholding certain antibiotics. So we can talk to the prescribers, but even more interestingly, we could talk to pet owners. And so that was something that was incorporated in the canine acute diarrhea guidelines. We had focus groups involving both veterinary practitioners, so people who were giving out those medications, but also pet owners, and asking them, well, if your dog has diarrhea, what's a meaningful improvement? If you were to take these antibiotics and it reduced the diarrhea by 12 hours, would that be worth it? Would you be happy with your purchase? Would you feel that it was worth the effort of trying to force it into your dog's mouth twice a day for 7 days if it just bought you that 12 hours less of antibiotics? And we could ask owners, and actually we found that probably they're actually only interested in going through all that rigmarole if you're seeing a 24 to 48 hour reduction in the duration of duration of diarrhea. So vets should be aware, what actually are we offering? What do we think the owner would want before they actually took those antibiotics home? And in the 15 guidelines, there was quite a lot of variability between the amount of stakeholder involvement that had been included to generate those guidelines. Now, predominantly this was veterinary stakeholder involvement rather than owners, but again, highlighting that if we involve them, if we get the owners to be part of generating these guidelines, they are much more likely to resonate. They are much more likely to be adopted and adhered to. So this is an area where we can actually change the way that we are developing guidelines so that they are going to be more impactful when they finally land. And before getting to the sort of the additional tools that we have, I wanted to mention this second article from actually the same group as I mentioned on the first slide, and this was published just last month, and they said, well, this is human doctors, not that we're not human, but doctors working in with patients rather than vets. And what they found was that both doctors and their patients had significant problems either delivering or interpreting the information around AMR. And they highlighted that the information that is currently available is often difficult to access. It's overly technical, full of abbreviations, your AMR, your MDR, all these things. Are they actually clear to our target audience? Do people understand what we're referring to when we talk about these terms? Probably not as much as we would like them to be. And can they relate to them? Do they actually feel that those suggestions actually relevant to them as an individual? Or do they think, well, actually that would be a problem for someone else in a different country, in a different situation. I don't need to worry about it. So how can they, why would they be motivated to do something if it isn't relevant to them? So we need to make sure that we engage with people on that level. There is a worry that all of us who are involved in stewardship have that schoolmasterly attitude that we are trying to tell people not to use things, not to do that, and is it excessively punitive in tone? And so can we alleviate that? And again, by engaging with stakeholders, we do improve the likelihood that they're going to adopt some of these measures. There's the worry about contradictory messaging. So we say, always complete the course, but use as little as possible. Well, how can you do both at the same time? Well, probably we do need to revise some of that messaging appropriately. But we want to make sure that the messaging has an impact and is clear to owners. The other thing that came out of this publication was this lovely little flowchart, highlighting that a lot of the messaging fails to achieve anything. And the overriding result of these multiple resources is that people tend to stick with their original attitude. So the bit that's bold and highlighted in the center of this figure is that they tend to retain or regain their initial attitude very quickly. So that's despite our best efforts. They're either not feeling that it's for them, so they're not motivated to proceed. They struggle to understand and therefore lack the ability to make the necessary changes. Or even if they can get through over those two hurdles, they may not buy into it enough that they will adopt changed behaviors. So again, just highlighting why we need to do more. So how can we engage more with pet owners? Well, the first tool that we've had and we've been using and trying to encourage vets to use is the non-prescription form. And the version on the right is the one that's accessible via the Protect Me poster, and it's freely downloadable. And can be adapted to your practice with your own logos, etc., to make sure that it's as accessible and useful as possible. And the one on the left is a very similar document produced by the team at the University of Minnesota. And what these do is they just remind owners, actually, we haven't forgotten that antibiotics exist. We know that they would be an option if your dog or your cat had an infectious etiology. But that's not what we're expecting. Or if it is, such as kennel cough, and we feel that there could be bacteria involved, well, we still don't feel that antibiotics are the treatment of choice. And we feel that the animal can get better spontaneously or with other supportive measures that won't require antibiotic use. So we can highlight the condition that we think this is appropriate for. We can offer alternative treatment options such as bland diet, increased fluid intake if it's an FLUTD cat. We're not supposed to use that term anymore. There's the red writing at the bottom, which is really just that safety netting to say we can get this wrong, and your pet may not improve, or they may even get worse, in which case this isn't a not now, not ever decision. It's just a single time point. And we will review this decision not to give antibiotics if there is a clinical need in the future. So it's recognizing that we may change our minds if the clinical picture changes. And I am a big believer in non-prescription forms because they've been shown to work. And this is a Cochrane collaboration paper published a few years ago, Human Medicine, looking at the use of either non-prescription forms, delayed prescription forms, or immediate antibiotic prescription. And this is for respiratory tract infections in people. Most common instance of inappropriate antibiotic use in people. So there's definitely ways to hold off using antibiotic in those situations. And what they showed is that whether you gave people the antibiotics immediately or held off them through a non-prescription form or a delayed prescription, you write the prescription, and instead of being able to go to the pharmacy and collect it straight away, it says next Monday. So you have to wait, and by next Monday you're better, so you rip up the prescription and you don't go and collect it. Didn't matter what version, what group these people were in, they were just as likely to get better. So clinical outcome unchanged. Patients did admittedly like to have access to those antibiotics, whether they were in the pot in front of them or in a prescription that they could cash in a few days' time. They liked that better than the non-prescription form, which was what we offer in veterinary. But you can see that the impact on antibiotic use, evidently, if you hand them out straight away, much more antibiotics used than if you add these barriers to owners being able to, or patients being able to collect them when they don't need them immediately. So that's the first tool that I think really incorporating that into practice. It's a way to close out the consultation, to deliver some of that information, and hopefully empower the vets to say, look, I'm part of solving this problem. Read a bit more about it. Here's the information. And you'll see certainly on the BSAVA one, we have the QR code that links to a whole suite of extra owner geared resources so that they can educate themselves and understand why we are making those decisions. So if you only have a 10-minute consultation, you can use a tool like this to say, look, I think that we're better off without antibiotics, and there are various reasons for this. You'll find out more information here. But we want to make sure that owners are still satisfied and they keep coming to see the vets so that they can get this information, get this advice appropriately when they need it. And one of the ways that we thought we could achieve this was through owner education and getting owners up to speed even before they entered the consultation room, so that they would be, again, more receptive to our not giving out antibiotics. And we had a brilliant intern at Willows a few years ago, Emma Wright. She's currently finishing off her residency at the Royal Veterinary College in London. And she designed an animation designed to convey some useful information to pet owners. This animation lasts about 2 minutes. I won't show the whole thing, but I'll just start it running. And what it's designed to do is to offer a common clinical scenario. So this is a dog with acute diarrhea, and the owners are asking for antibiotics, as they always do, obviously. And the vet's now going to explain why that's not the right answer and why they shouldn't be doing that, or why they shouldn't be giving out the antibiotics unnecessarily. And Emma then talks about, well, antibiotic resistance and the threat from it, and hopefully using simple terminology is able to articulate some of the key messages around this problem. And the message goes on and it gives owners a little bit of an idea as to what they can do. So don't pressure your vet. Don't go and ask them and say, where are my antibiotics? Recognize that there may be situations where it's not the answer and that your dog and you better off without them. So it is simple, it's quick, and it's relatively straightforward, hopefully. But we ran it as a randomized controlled trial. So half of the population were, or half of the people who came to the consultations were shown this video and half weren't. And we then looked to see what difference did it make to their attitudes from a sort of qualitative survey from watching that film. And we found that actually, if they watched it, there were these marginal changes, a little nudge in the right direction, so that they would be maybe less likely to request antibiotics from their vet for diarrhea. So they would be less likely to expect them if their dog had diarrhea, because they recognize the dangers of increased antibiotic use, causing AMR and problems of that nature. So simple tool, something that can be delivered in a waiting room, either via the waiting room television, if you have receptionists who are incredibly tolerant, because the sound does become somewhat repetitive, but you can put it on a QR code and people can watch it on their phones. And Emma then went on to organise this tool to be translated into some 20 different languages. So depending on where the cultural basis of your client well, you can decide, well, maybe they can watch it in Albanian or things like that. And that's been published in JAC AMR a couple of years ago now. So that's the second tool that hopefully will make a slight difference and can get your owners ready to then have a non-prescription form and leave happy but empty-handed on the antibiotic front. But let's imagine that they do leave with antibiotics and they go home and then their dog's sick the first time they give them, or they get their hand half bitten off, a la Jaws. So they say, right, I'm not using those again, and they put them in the airing cupboard or in their home pharmacy, and say, well, that's not an option for the time being. But what if I'm ill? Maybe I'll need them. What if another of my dogs is unwell? I'm going to save them. And we are confronted with a new problem, and this is the problem of leftover antibiotics. And so over the last 3 years, we've been working to try and solve that through the antibiotic amnesty. And this was built on some great work from the team in the Midlands in NHS pharmacies, led by a whole group of pharmacists there. And they based this on the survey that had shown that of 500 UK patients, about 1 in 6 had leftover antibiotics, and a tiny minority, less than 10%, did the right thing, brought them back to the pharmacy for them to be disposed of safely. About a third of them threw them away, either in household waste or flushed them down the toilet, leading to environmental contamination and them leaching. Effectively, it's bad enough that they go into the animal and cause or promote resistance in the microbiome. But if you just throw these undiluted antibiotics into the environment, you're doing the same thing. You're creating that environment that will favour resistant strains of bacteria. So throwing them away is not an answer and can cause a lot of harm. And we know that there are antibiotic residues in rivers and waterways across the world. A third of people hold on to antibiotics, as I said earlier, just so that they can use them again. We even had a short-lived health secretary who said that that's what she did, and she would give them to her friends when they were poorly. She wasn't a doctor. Luckily, she wasn't a health secretary for very long either. And we want to discourage that because it can increase the likelihood of adverse effects. It can delay the diagnosis, and obviously it can potentiate AMR. So we want to break those habits, and the way that we wanted to do that was through the antibiotic amnesty. And just to say that those data were for humans and patients and their own antibiotics. We ran a similar survey, smaller numbers, about 140, and similar, well, scarily, slightly more pet owners had stockpiled these antibiotics and often were dealing with them in a similar fashion, i.e. just chucking them in the bin or holding on to them for when they thought they might be left over. And people end up in this situation for a whole host of reasons. And once we give them out, it's an assumption, but a false assumption, that all antibiotics that we're prescribing end up in our target animal. Well, there are loads of reasons that might not happen. The animal can die, and so then they're going to struggle to take them. They might get better, and you think, well, I'm not putting myself through that to do it. They may have adverse effects and other things. So there's a lot of reasons why leftover medications, not just antibiotics, occur. And we should be recognising that and trying to support pet owners to then do the right thing should they find themselves in that situation. So the antibiotic amnesty, as I say, run initially in NHS pharmacies in the UK, but taken up and really quite encouragingly by vet practices around the country as well, to make this very much a One Health initiative. And we were delighted just in the last few weeks to receive a contact from a team in Kenya who have been trying to do this, enact the antibiotic amnesty where they're working as well. And the idea really is to recognise that you may have leftover antibiotics at home, and rather than just allowing them to be thrown away, can we encourage people to bring them back so that they can be safely disposed of? And that does take a lot of careful messaging. We've charged our clients for these. They've paid a good amount of money to have the antibiotics. Now we want them to give them back to us for free. Well, we need to share this messaging so that they can happily do that. There is a cost to vets to sometimes to dispose of them and to pay for that in incineration. So it's not actually so that we can make money again from them. It is really to show that we are part of this solution and we're doing the right thing. There are lots of resources that are available for this. There are stickers that can be put on antibiotic packets. There are posters that can go up on the practice wall. And we've been running this every November since 2022, and we found it's been a really nice way to engage with clients. When you say, well, don't forget, if you do end up with leftover antibiotics, bring them back and we'll dispose of them safely, it's a conversation starter. And they say, well, why would it matter? Well, let's talk about AMR. Let's get you on side and realize, well, do I need these antibiotics in the first place? And maybe we can avoid even the problem. Or what's the optimal dose? Surely do you really need to give me 4 weeks worth of antibiotics for this cystitis case? Well, no, we're optimistic that we can solve it with 3 days or 4 days. So there might be ways that this encourages shorter durations as well. So I think it's another example of a win-win strategy that we should use. And it's one that can engage the whole veterinary practice team. And that's important because often this burden falls on the vets as the prescribers, but actually it's a problem for all of us. And it's great when the whole veterinary team, be it the nurses, the front of house staff, who can really make a contribution and discuss these subjects with pet owners. And so we found it very, very positive on that front as well. We hope that by sharing this information more widely, we can encourage people to do the right thing. We know that fed the right information, 3/4 of people will automatically act accordingly, and they will bring that back. So you can change it from 8% to 75% just through sharing this message. That's a massive change, and can really make a useful difference. We want to know if this is just a UK problem, and so we have, through the WSAVA, we've been running a study to see what are the different legislations, what are the different arrangements and practicalities in different geographies. So whether that's in Australia, India, South America, we're trying to understand that and some targeted guidance, because there are lots of practices that can be improved in different situations. Hopefully she'll follow in the next year or so. But we do want to make sure that we look after antibiotics, not just in that prescription step. So that's the first hurdle. But if we are using them, let's use them for the right duration. But if they're not ending up in the animal, let's make sure that they are not thrown into the environment or saved for another day as well. I've got a couple of minutes just to wrap up this talk, and I want to mention 2 other initiatives that we've been running to try and share this message as widely as possible. And the first is the School Ambassadors Scheme. We've piggybacked on a initiative that's come out of the UKHSA, used to be called Public Health England. And what they were doing is they were creating motivated individuals who would go into schools, be it primary or secondary, and deliver a talk, a brief presentation centered around antimicrobial stewardship, infection prevention control. And I think I've talked a lot to all sorts of different audiences around the world, but probably the best one ever is when you go to a primary school. When you ask for a volunteer, you get 300 hands up, eager people to try and come up and be on the stage with you. And they really do listen. And when you present the diagram there is of this sort of glitter experiment, a bit of glitter and a bit of shampoo or something like that, and then play that shaky hand man game, and you find that the glitter goes right away down the line. And if that happens with glitter, what happens with bacteria? So suddenly they're all thinking about how important, and they know the song. They know how to wash their hands. They can demonstrate that. And hand hygiene, we all know, the biggest, most impactful step that we can make in limiting transmission of infections. So I think that children are undoubtedly the people who are going to determine the success of avoiding the antibiotic apocalypse. So if we want to make that difference by 2050 and bring those numbers down, we need to engage with the future generation. It's my children that make sure that I recycle everything. So if we have plastic bottles at home and they go in the wrong bin, there are lots of angry voices to make sure that we do the right thing to protect the planet. Well, let's try and convert them also to make sure that they are aware of antimicrobial stewardship. And even if they're not using those terms, they can hopefully encourage correct practices that will then echo into their parents' behaviour as well. And I think recognising that no individual is going to solve this problem, but we can all do our little bit, is a positive thing. And I would encourage every vet, every person really, to become an antibiotic guardian, and you can go on www.antibioticguardian.com to achieve this. I attended the meeting, and embarrassingly there are more dentists that have done this than vets currently, so we all need to make sure that we make this pledge. There are pledges that are centered on different professions, so we can all decide what's the one thing that we're going to focus on to make sure we do improve our antimicrobial stewardship. So I hope that we can all find something that we could do to try and be part of the solution. And just to finish, summarise already some of the limitations, but the Wellcome Trust have generated this report. And I think it just does remind us the importance of trying to frame things correctly. So we want to make sure we present AMR as something that is relatable. So trying to use terminology that owners are going to understand, and rather than frighten them necessarily, we can make it personalized to them. So the fact that 10 million people are going to die might just seem like a statistic. What about the impact it could have on their need for hip replacements, on chemotherapy that might be important to a family member? Recognizing the need to use plain language. And that video that we showed, we employed a well, one of our co-authors was a human pharmacist who has a lot of experience in trying to use language that is going to be understandable for the vast majority of the public. So really trying to select terms that will make sense to our target audience. We've talked about making it personal and universal. I'll come back to that in a moment. And recognizing that we want to do things immediately so that we get people on board to do things straight away. And finally, just a mention of Vanessa Carter's work, and sometimes using sort of these personal messages and stories that can have a major impact. And she's such an amazing ambassador and advocate for all things around antimicrobial stewardship in that One Health message. Maybe we need more of these examples in our own work that will help make it relatable to our pet owners. So in conclusion, there are lots of different ways that we can get owners involved. Please do consider using a non-antibiotic prescription form. Feel free to use the owner animation. It is a free resource. It's accessible via the eNavat website, via the Protect Me poster, on the BSAVA pages. We're really keen for vets to use this, and feedback. Let us know what works and what doesn't, and how it could be improved so that we can make future iterations. The antibiotic amnesty will continue to run, and we are really trying to get as many different countries signed up. And it doesn't just have to be in November, it should be a year-long thing. We just maybe make more of a song and dance about it to sort of coincide with World AMR Awareness Week. The School Ambassador Scheme and the Antibiotic Guardian Pledge are the simple tasks that can be effective as well. Thank you very much. Sorry. And if you've got any questions, please don't hesitate to send me an email as well in the future.
Thank you very much, Fergus. I've already received messages from people saying, this is such a great talk. So if you've got questions, please pop them in the Q&A, or you can, I think, request to be unmuted by Kaz. There are a couple already. Stephanie would like to know, I think from one of the early slides when we were looking at the defined daily doses and the lack of shift, I guess, in the last 10 years. Stephanie wants to know what happened in 2015 when there was an initial big drop in defined daily doses there.
I would love to say the vets made a big difference and had tuned into something. I think it was more a way of 2014 was the first time they generated the VARS report. So I think there were problems in data collection and handling. So I think that first change, unfortunately, is more attributable to working out how to collect the data than any actual prescribing benefit, sadly. So really, we have to count it as being pretty much the same as the year before, sadly.
Yeah. Anna, would you like to ask your question live, or should I read it out? Oh, I might read it out. This might be a tricky one to answer, but given that many of the conditions driving inappropriate antimicrobial use are preventable, for example, skin conditions, diarrhea, fluted, are resources better spent educating clients about management and prevention of those rather than about antibiotic prescribing or AMR?
I don't know. I think that how best to there are opportunities to do both. And I was at the WOA meeting in Paris a few weeks ago, and really their focus at the moment is on vaccination, and not just from a companion animal health basis, but across the board. And the value in trying to do disease prevention maybe takes away the need for a lot of antibiotic use. So I do agree that there are opportunities to try and minimize those things. And certainly if you're having a puppy consultation, or if you're seeing a Westie or any other animal with a predisposition to certain antibiotic use conditions, then raising them and encouraging sensible preventative measures, whether that be vaccination, whether it be grooming behaviours or grooming things, or whatever other measures can be adopted. I'm very, very much in favour of doing that, and I think we should provide owners with as much information as we can. I recognise that lots of the time vets find themselves in the situation where the horse has bolted and they are confronted with a animal with diarrhea or with pyoderma. New ISCE pyoderma guidelines are now out and available. Annette's done an amazing job with those. Please do read them and adhere to those sort of topical guidelines. And yeah, so I think that there's still a place for antimicrobial stewardship messaging, because we are still going to be seeing animals that have, unfortunately, the preventative option has been missed. But it's not to say that we shouldn't be banging that drum very loudly at other opportunities too.
Yeah, absolutely. James would like to know what your thoughts are around the finish the course message, which came up.
Yeah, and it's a dogma that we've had for years and years, and I think that it is going to change. It's hard, isn't it? Because you've heard that at the doctors. They've always said, look, actually, you've got to do it. And the argument has always been, well, if you don't finish the course, are you going to be generating more resistance through incomplete microbiological cure? Well, there's just no real evidence for that. And I think that we're probably going to be moving towards a stop when you're better in human medicine. So relying on clinical measures to determine what the optimal course length is. I mean, if you look at Brad Spellberg's work and he's done a lot of this in human medicine, he's shown that shorter is better time after time after time. And some of the differences, osteomyelitis, 42 days, just as good as 84 days worth of antibiotics. That's 42 days unnecessary antibiotics going to a lot of people for that condition. So you can get away with a lot less. So how do we apply that to veterinary medicine? I think that's harder because we are relying on pet owners to make the decision. So we need good evidence. We need what is the optimal duration for particular conditions. And we've got a study running at the moment called Stop on Sunday, where we're trying to determine what the optimal length is for managing sporadic cystitis or sort of bacterial cystitis in female dogs. Probably it is, as the ISCAID suggests, 3 to 5 days. But if we could prove that, and if we could say, look, a 3-day course is going to be fine, that's our starter at least. That would be really useful. And we would be able to say, that's your course, and extend it if they're required. Where I get a little bit nervous is saying, how do you empower an owner to know when their animal is completely better? And sometimes we don't have brilliant surrogates. I mean, they've been using CRP. You'll have seen the study in AVMA about or in JAVMA it was, about pneumonia, and CRP being 2 weeks being as good as 4 weeks, CRP being another way to try and reduce the antibiotic course length. But it's a relatively blunt tool, and we'd like to find better ways to determine when you can stop those antibiotics confidently without increasing the risk of relapse and increasing the resistance of recurrence of a multi-drug resistant pathogen, which would be the absolute disaster situation that you undertreat and end up with an untreatable.
Yeah. Thank you for that very comprehensive answer.
Sorry.
And we do all have to fight that dogma together. I think we have time for one more question, and from John Prescott. Fergus, thanks for a great talk. In terms of small steps that have cumulative value, you mentioned non-prescription forms, delayed prescribing, and leftover antibiotics, and mentioned in passing benchmarking, the Lord of the Rings, and hand hygiene. How do we focus on the things that will have the most impact, and how would you prioritize them? Or is it all of the above?
I think in many cases it is all of the above. I think it's working out what's the one that works for you. And I like the benchmarking approach. And when I go into practices, often I will try and get their data beforehand. And that graph comes from a practice that I went into. And the reason it's the Lord of the Rings is just so that I can anonymize them and they didn't embarrass anyone in that particular thing. Because crucifying people for their antibiotic use is entertaining, but probably not very fulfilling for them. So we had those discussions. I think that there are practices where metronidazole use is the real problem, and we can focus on that, and by showing that people can get away without using it, and then how can we help them? How can we get them out of that habit of reaching for metronidazole? And often with antimicrobial stewardship, we're good at saying don't do that, and we're not so good at saying do this instead. And that's where hopefully a non-prescription form, owner in education, can be ways to sort it out. I mean, hand hygiene, I accept. All of these things are important. I'm massively into surgical antimicrobial prophylaxis, and I'm trying to encourage people to reduce their antibiotic use around clean contaminated procedures, but that's only feasible if they have good infection IPC behaviors at work. If they run around picking their noses and playing in the mud before operating, it's going to go wrong. I'm not sure antibiotics would solve all that problem, but it would be it wouldn't be the right position. So we've got to get everything right, and it is just trying to work out where people are at in this journey, in their own journeys, and applying. So hopefully, if we can generate a suite of resources, and we can say, right, year one, let's focus on canine acute diarrhea. Year two, shorter is better. Year three, these things. And so I think there is a progress to be made, and different practices. Some practices are already doing an amazing job. They have such low antibiotic use. It's phenomenal. And you could do a benchmarking on a country basis, couldn't you? And you'd see that Sweden is doing phenomenally well. And dogs aren't all dead in Sweden, but they hardly touch antibiotics. And then you go to America, and I appreciate, luckily we're not online in America, but there's definitely room for improvement there. So, yeah, all these things are important, but you have to work out where you're at and which is the one for you. Sorry, that's not very helpful.
No, I think that's fair. It's sort of like trying to choose a favorite child, is trying to choose your favorite antimicrobial stewardship strategy. We have to do them all, and they're all important. Well, I think that's all we have time for today. So again, thank you for everyone joining. We had a huge number of participants online today, including from many countries around the world. And a reminder that this recording will be available on the NCAS website after the session. The next NCAS webinar will be on Wednesday, the 17th of September, and the topic is sepsis. Thanks, everyone.
Thanks, everyone. Bye.